Thank you for having me here. As mentioned, I'm Meena Seshamani. I work at MedStar Health, where I lead quality improvement for the health system. And before that, I worked at the Department of Health and Human Services in the Office of Health Reform. And I was asked to come to give an overview of delivery system reform and kind of what has been going on over the past few years in terms of payment models, et cetera. And I thought, given all of the talk about markets in healthcare and how markets work or don't work, that I would bring all of you back to your Econ 101 from way back when. I'm a health economist by training, to talk a bit, to start with, about healthcare markets in general, what works, what doesn't, what the imperfections are, and then how that leads to a lot of the work that has been going on in the policy space and delivery system reform. So I'll start with talking about healthcare delivery market failures. There are kind of, as you know, two aspects to the healthcare system that intersect. One is the healthcare insurance market, the other being the healthcare delivery market. Then I'll go through an overview of delivery system reform as it was envisioned in the time of the Affordable Care Act and in the Obama administration, talk about payment reform goals and commitments that have been made in the private sector around these. And then I'll go through some of the programs that are in existence, the Medicare Shared Savings Program, also known as Accountable Care Organizations, bundled payments, and then the Quality Payment Program, which came about through MACRA, and which has MIPS and the Advanced Alternative Payment Models. So first, in terms of the healthcare delivery market, again, to come back to our Econ 101, when a market works, you have perfect competition where sellers can enter and exit the market with no friction, where you have consumers who have full understanding of the costs and benefits of the transaction that they're engaging in, and that they also can move seamlessly across the different sellers. So I think just with that explanation, you all can say, is healthcare like that? Not really. And there are several reasons for this. One aspect is market distortions, which are created in part by our third payer system, where you have a third-party payer, such as an insurance company, that's actually the one that's paying most of the bill. So when you have a patient coming in to a doctor's office, they're not experiencing the full cost of the service that's being provided, and that is termed moral hazard. If you've heard that term. A second is the distortions that are caused by a fee-for-service system, where the services that are valued for the provider or the seller, some may be valued at different cost values, some may not be reimbursed at all in terms of phone calls and follow-up emails. And so that also leads to distortions, because you're not now accurately reflecting the costs and benefits that are felt in that transaction between the patient and the provider. A second aspect with healthcare markets that is imperfect is information. So again, in a market that works seamlessly, the consumer knows what they want and purchases that good. In the case of healthcare, a lot of times the patient doesn't know what he or she needs, and the physician knows more about the healthcare services and how they will affect the patient. Around cost and quality in general in the healthcare system. If someone is going to try to find a provider, try to figure out how much various services cost, it's very difficult in the current environment to do so. So market distortions, information asymmetries, coming to competition. Our healthcare market is very sticky, and by sticky meaning that when a patient has an insurance company, has a provider, a lot of times they don't want to change to someone else. And so that affects competition. And also high concentration. There have been numerous studies done about the increasing consolidation in the health insurance side, and the recent proposed mergers for Cigna and Anthem that would have really led to this conglomeration of a top 3 insurance companies that didn't go through, and also on the hospital side in particular. And so again, that gets to the issue of, do we have a really competitive market? And then the last two, externalities and public goods. So externalities are when the benefits of a transaction, the full scope of benefits are not considered. So a good example is secondhand smoking. So, the person who is deciding to smoke based on, presuming they know what the risks are to their own health. They're making that decision, but that decision is also affecting other people as well. And so in healthcare, you have a lot of these externalities. Another example is the conundrum with preventive services. When you provide services where the benefits are not going to be seen for years later, when an insurance company says, well, why should I pay for that service? Because when that patient doesn't develop something 10 years down the line, they're no longer going to be one of my enrollees, and I'm not the one who's going to see the savings from having provided those preventive services. So that's another example of externalities and how the market does not work in an efficient way. And then finally, public goods, where there ends up being an incentive to free ride, where I don't need to get it because if everybody else gets it, then I still got the benefits. And the classic example with this is vaccines and herd immunity, where if one person doesn't get vaccines, if everybody else is getting vaccines, then they get to free ride and they get that benefit as a classic example. So I just wanted to start off with describing how, as you see, healthcare really is not a perfect market, and there are a lot of issues with the way the market works that has led to a lot of the changes that have been discussed recently. So what I'll do is I'll go through some of that. So moving from all of those ways that there are these imperfections in the way that the market works, there are kind of three aspects to delivery system reform, again, to try to address some of these issues. The first being incentives, and this is going to be primarily the focus of what I'll talk about, promoting value-based payment systems. And so a lot of the work here is in these alternative payment models where outcome is part of what is used for determining reimbursement, and where payments are done more in global budgets or lump sums, again, to get at the issue of certain services that otherwise would not be reimbursed, such as making phone calls to patients, et cetera. Instead, it's more about just giving a payment and then providing flexibility in terms of how care is provided. The second area is care delivery, so encouraging more integration and coordination of clinical care services and bringing in more of population health. And part of care delivery is also supporting patient engagement in decision making. Again, all coming back to imperfections that are in the healthcare market. And then finally, information. And so this includes electronic health information, transparency and cost and quality, and also bringing evidence to the point of care for better decision making, so using decision making support tools, for example. So back in 2014, HHS and CMS set goals for moving from traditional fee-for-service payments to alternative payment models, with a goal to have 30% of payment models in 30% of payments in alternative payment models by 2016, which was met, and 50% by 2018. And some of these models are the ones that I will be talking through next. Of remaining fee-for-service payments, the goal was to get 85% linked to quality outcomes by 2016 and 90% by 2018. So, obviously CMS is one component of, it's a large component of payments, but Medicare and Medicaid together make up 1/3. So really, there has been a lot of effort to link public payers with private payers, and also providers, patient groups in these partnerships, so that things are moving in a more coordinated fashion and that have input across the spectrum of our very complex healthcare system. So one such example is the Healthcare Payment Learning and Action Network, which has over 4,000 individuals and 600 organizations. It's chaired by Mark McClellan, who was head of CMS under Bush, and Mark Smith, who is at UCSF. And here, some of these partners have put forward their own goals for how much of their payments they want to have in value-based reimbursement. Importantly, with this Learning and Action Network, they have various work groups that have come up with white papers that provide guidelines for different models. So again, so that Aetna doesn't do one thing that's diametrically opposed to what United is doing, and then Cigna's doing something else, and then as a provider you just pull out your hair and you say, I give up, I can't deal with all these different things. So a lot of efforts in terms of trying to streamline all of the various quality measures, because there are way too many quality measures that were different for different programs, and also guidelines for things like, if you have an episode of care, what's the start of the episode and what's the end of that episode? And what costs are included? And how do you attribute a patient's care to a particular provider? So providing guidelines with the input across all the different players in the healthcare space. So some examples of some white papers that have been done on alternative payment model, having a basic framework, looking at population-based payments such as accountable care organizations for how you measure performance, how you share data, because if you have a primary care provider, they need to be able to get data from all the various avenues that a patient is receiving care. And then a lot of work around the bundled payments that I'll talk more about, providing guidelines for bundled payments with joint replacement, cardiac care, and maternity care. And they're continuing to work on these white papers that are being used by payers and provider groups as well. The Healthcare Transformation Task Force is another consortium. This one does not include the government. The previous one includes CMS and also states because of their Medicaid programs. And this is patients and payers, providers, employers, where again, a lot of them have come together and said that they're going to put 75% of their businesses under value-based payment arrangements. So moving to now focusing on CMS and some of the various models that have come about, particularly in that alternative payment model space. The Medicare Shared Savings Program, which is accountable care organizations, it was established in the Affordable Care Act, and the idea here is for groups of providers to take accountability for the cost and quality of care for their patients. There are 3 tracks to this program. The first track is that if a provider group meets quality benchmarks, then they share in the savings if their actual costs are lower than what was predicted. The second track is that if they meet quality benchmarks, then they share in the savings, and they have a greater percentage of share in the savings, but then they also share in the risk if they end up costing more. And the third track, or Pioneer ACO, is for more seasoned health systems and providers, whereby there's a greater financial risk entailed. And with each of these tracks, as you move along, there's relaxing of various regulations that had been put in place under the fee-for-service system. And I'll come, one of them to explain, like the SNF rule, where you have to stay in the hospital for 3 days in order for Medicare to reimburse SNFs. In the Track 3 ACO, that's waived, because the idea is, if you are telling the provider, take care of the patient the best way you take care of the patient, we'll look at outcomes, we'll look at cost, but we're not going to micromanage to that degree. So there's relaxing of various regulations that had been put in place before because of this fee-for-service environment where you had different people making the healthcare decisions, dealing with the payments. It was much more disparate. So some additional models in accountable care organizations. One is the Next Generation ACO. So this takes that Track 3 to the next step. And it's really designed for providers that are experienced in coordinating care. So this gets into enabling telehealth services, having home visits, encouraging alignment of the beneficiary. So if a patient sees the ACO provider, then the copay is reimbursed. Again, to encourage patients to stay within that network of coordinated care that's being developed. And along with that, there's higher levels of financial risk and reward with this model. And there are some disease-specific models that have come about in part from provider groups that have requested them. So there's one for dialysis centers where they can have their own accountable care organization based on dialysis clinics for renal disease. And one thing that I'll say with having various models, because I think There's no silver bullet. If there were a simple answer, it would have been done already. And so the idea really was to enable some testing and to enable providers to try things that, and then we have to see how it goes and make adjustments along the way. So there isn't a one-size-fits-all, one model that's being used for everyone. There are different programs that providers can use. So with the episode-based payments, there's a program, BIPSI, the Bundled Payments for Care Improvement. It's a voluntary program where providers are reimbursed for an episode of care. This episode of care can start with the inpatient stay plus the post-acute care, or it could be just post-acute care. And there are 48 different episodes to choose from. I've given some examples of some of the diagnoses around which there are bundles. There are more than 1,500 participants in this across the country: acute care hospitals, rehab facilities, home health agencies, group practices that are participating in these bundled payments. And again, the idea here is that for a specific episode of care, the providers get a set amount of money. They meet quality benchmarks, and if they end up spending less than that target amount, they reap the savings. The joint replacement bundle, this one was in the news pretty recently. It was the first mandatory model that CMS put out in 67 regions that were randomly selected. It was proposed in regions that meet a certain volume of procedures, a certain threshold in terms of not having rural hospitals or critical access hospitals. There's now a proposed rule to make it voluntary in half of those regions. It's a 5-year payment model for hip and knee replacements, again with an episode-based payment from surgery through recovery for 90 days after discharge. And along with this, there are tools that are provided to encourage better integration of hospitals and post-acute care facilities. And there has been quite a lot of movement, particularly in the post-acute care space, with post-acute care providers wanting to do a better job of coordinating with hospitals and kind of selling their wares in that regard to make the hospitals more competitive for this kind of an approach for care. So that's kind of going through some of the models that are in place. And after some of those models had started, Congress passed MACRA, or the Medicare Access and CHIP Reauthorization Act. Pretty significant legislation. It repealed the SGR and created the Quality Payment Program. And in this Quality Payment Program, there are 2 tracks. There's the Merit-Based Incentive Payment System, MIPS, and the Advanced Alternative Payment Models, which provides bonus payments. So I'll go through each of those. So this is now in place of SGR. So in the Merit-Based Incentive Payment System, this is basically taking fee-for-service and attributing some adjustments to the payments based on various measures. So quality, advancing care information, this replaces meaningful use. The quality measures replace RS, clinical improvement activities, and resource use measures or cost, which hasn't started yet, which is going to start next year. And so payment adjustments are made based on performance. They can vary plus or minus 4%. For high-performing providers, there can be a bonus of as much as an additional 10%. So just going through each of those 4 categories, under quality measures, you have to report up to 6. I just provided a list of some of the quality measures that are relevant for otolaryngology. Some of them are more specific, like acute otitis externa. Some of them are things pretty general, such as documenting an advanced care plan, closing the referral loop, so sending a note to the referring primary care physician, medication reconciliation, doing tobacco screening, alcohol use screening, and then perioperative antibiotics and VTE prophylaxis are also in there as well. For advancing care information, a lot of these are things that came from meaningful use, but importantly, meaningful use was very much an all or nothing Either you did everything perfectly and then you got credit, or you got no credit. Whereas now it's more graded in terms of it's a point system whereby you get credit on a graded scale. And some areas here doing e-prescribing, providing a patient portal, sending a summary of care or receiving a summary of care from hospitals, et cetera, and having security risk analysis for security of the information that you have in your EMR. The third bucket is clinical improvement activities, and here you attest that you completed up to 4 improvement activities. And again, I've given some examples of these, like providing 24/7 access to clinicians who have real-time access to a patient medical record. So physician is on call, and from home they can access the EMR. Engaging patients in developing a plan of care. A lot of the certified EHR technologies have some basic decision-making tools in them that satisfy this. Providing specialist reports back to the referring physician, and demonstrating that there's engagement of clinical and administrative leadership in practice improvement. I'm just giving some examples here. So that is the MIPS, which is basically has revamped the fee-for-service side of the house. And then there are bonus payments for providers that are in alternative payment models. So coming back to the accountable care organizations, for instance, if an accountable care organization qualifies as an advanced alternative payment model, then providers do not need to go through MIPS, and instead they receive a 5% bonus on their Medicare Part B payments. So the criteria for an advanced alternative payment model, and this was set in legislation, is that the payment model has to bear more than nominal risk. So if you remember when I talked about the accountable care organizations and track 1, providers would share in the savings, but if they cost more, they don't share in the cost. That wouldn't count because you need to have some risk on the downside. Quality measures should be comparable, which pretty much all of these models have, and the participants have to use certified EHR technology, again, which all of these models pretty much do. So a lot of the accountable care organizations, they do include otolaryngologists. So for instance, MedStar, the otolaryngologists are included in the ACO, and so it's all determined by the ACO, and so the MedStar otolaryngologists don't have to do anything. Yes. A lot of this comes down to Billingtons. So if you have an ACO that's related to your Billington, then you can go through that avenue. And so then this just summarizes, coming back to what was put forward for how CMS wants to move in terms of payments, and then MACRA, how do those two overlay? So if you remember, in 2016, the goal was to have 30% of Medicare payments in alternative payment models and 50% by 2018. The advanced alternative payment models in MACRA, oh, thank you. The advanced alternative payment models in MACRA, just in the legislation, are more restrictive. I gave that example of the accountable care organization, that if you only take upside benefit and not downside risk, it doesn't qualify. So that's why there's a dotted circle for what would qualify as an advanced alternative payment model for the payment bonuses in MACRA. But that 85% of fee-for-service linked to quality is basically the MIPS program, and that's what everybody is getting switched into. So that is just to hopefully give you a sense of how it overlays, because MACRA came about after this had started. And that's it. So I think time for questions. Right.
Many otolaryngologists may service a few different hospitals. Mm-hmm. So is that APM applied for general practice, private practice
There can be. I don't know all of the participants in the ACO, so that's my caveat, is that I don't know who all the ACO participants are. This is one area, to your point about the different EMRs, this is one area where there has been quite a bit of innovation. For instance, Privia and Aledade, there are a lot of companies that have created platforms to enable better sharing of information across independent providers, again, to encourage the continuation of independent providers. Privia is very prevalent in the DC metro area, especially with the small primary care practices, to help them group together. The other thing that I would say is, and I think all of you know this, that a lot of these models started with primary care, and some of them have ended with primary care. And so one of the things that the legislation created was a physician technical advisory committee. Actually, an otolaryngologist is the chair of that committee, and it basically is comprised of physicians who evaluate alternative payment models that are brought to them to see if they then qualify as an advanced alternative payment model. So for instance, NCQA has worked with various specialty groups to come up with patient-centered medical homes, for instance, for diabetics, for the endocrinologist, for multiple sclerosis patients, for the neurologist. So several of these patient-centered medical homes are being brought forward as potential to be able to be at the center of the model rather than just kind of being on the periphery with the primary care in the middle. So there is movement in that direction.
Does a single ACO have to be all or nothing? I mean, like, does every member of that ACO have to be MIPS or the other, or can there be a mix?
So that's a very good question. So the way it works is, if you are a member of the ACO, in order to get the 5% bonus, you also have to have a certain percentage of your patients in the ACO. If you don't meet that threshold of the certain number of patients, you are waived out of the majority of the MIPS requirements because you're already satisfying quality, you're already satisfying the care information, you're already satisfying the clinical improvement activities. You just don't get so you don't have to do much in the way of reporting, but you just don't automatically get a bonus.
A lot of us are members of multiple.
Correct.
So it gets kind of funky.
Correct, yeah. Bribing and other such things. And again, this is where there is, like, for instance, again, talking about the DC area where you have providers who were on paper and then joined with like Athena Health or one of these others that then, they integrated into this overall platform.
I would disagree. Private practitioners not on EHR can participate in MIPS.
You can participate. It's just, a lot, and that's how like Regent and all can potentially help. But you can participate. You can definitely participate. It's a question of, how well will you perform? How easy is it to do? That's more the issue. Correct.
But practically speaking, it would require inputting a tremendous amount of information.
Right.
A lot of staff, a lot of money.
Yes.
A lot of staff for very little return. Right now. Correct. It's only 4% the first year.
It goes up to 9%.
Of your Medicare population. Of your Medicare. Goes up to 9% next year.
Yeah, and it goes up to 9%. It's only Medicare Part B payments, correct?
It's a potential 36% swing. How do you figure? Because the top performers, assuming it was presented to me once about a year and a half ago that you don't have to outrun the bear, you got to outrun the guy who's behind you. And so the point is that the money comes from the people who don't perform well and it goes to the people who do perform well. And ultimately, the top performers can gain 20% while the poor performers lose 9%. Of the Medicare. Right now.
But yes, thank you for that clarification. You can participate. It's just a question of how will you do, how easy is it to participate.
And you can participate depending on what you want for various durations of time.
Yes, exactly, because
You can do 1 month, 3 months, or an entire year.
Correct.
Depending on what you're looking to accomplish.
correct. There are, especially with the first year, there is a lot of flexibility in terms of how long you report and how much bonus you're then eligible for. The idea being that it would provide more of a slope to getting to full participation, correct?